Good evening and welcome back to another lockdown live session with Ivodent. Before we start, just a few house rules. If you hover on the top right-hand corner of your screen, you'll be able to select between speaker view and gallery view. Yourselves and turn your videos off for better connectivity. If you hover around the bottom middle of your screen, there's a chat box. Should you have any questions during Andrew's presentation, please keep the questions coming. Once Andrew is done with his presentation, I will ask him all the questions that he'd not yet covered during his presentation. This evening, we are fortunate enough to have Dr. Andrew Ellis, owner of Patheodent Dental Healthcare, sharing his valuable knowledge on the principles of occlusion in implantology. Andrew is the current Vice President of the South African Academy for Aesthetic Dentistry and presents various courses on occlusion through the Academy. What Andrew will be sharing with us this evening is only but a summarized overview on occlusion. For more in-depth details, be sure to join him on his one-day, full-day course on occlusion. This is money well spent, and I can guarantee you, once Andrew is done with you, you will surely grasp occlusion. Andrew, thank you very much for your time. It's a privilege to have you here this evening, and we look forward to learning from you. Over to you.
Thank you, Stephanie, for that very, very kind introduction. I appreciate it. And good evening, everyone, and welcome to another one of these Ivodent online lockdown sessions. I'd also just like to thank Gary and Paula for inviting me to speak here today on behalf of Ivodent on one of these sessions. I'm looking forward to it. It's a new experience for me, and it should be great fun. Again, welcome to everybody that has tuned in, and I look forward to sharing some of this information with you tonight. The topic tonight is occlusion in implantology. And for any of you that know me well will know that I really do wholeheartedly believe that functional occlusion is the cornerstone of all dental treatment planning and all dental treatments. And it doesn't matter which sphere of dentistry we're looking at, whether we're looking at restorative work or orthodontics or orthodontic surgery, or like in tonight's discussion, if we're looking at implantology, it definitely remains an important part of what we do. And so in a multidisciplinary approach, occlusion is of paramount importance in order to obtain a stable and a successful and a long-term treatment result. And that's what we all desire to achieve for our patients on a daily basis. I did say in the blurb, if you read it, that implants are teeth. So we can't treat them exactly the same as teeth because they will not behave in the same way under occlusal load as teeth would behave. But regardless of whether we are looking at teeth or natural teeth or whether we're looking at implants, what we are trying to achieve is occlusal harmony, because with that, we prevent any occlusal overload and we prevent noxious forces from being exerted on our teeth or our implants. And I just think that cannot be, the importance of that cannot be underestimated. So if we move forward, I'm going to say that determining the occlusal scheme for the restoration of implants requires very careful consideration. Occlusal overload can be regarded as one of the main causes, or at least a contributory cause, of peri-implant bone loss and implant prosthesis failure. If we get crestal bone loss, it will increase the anaerobic sulcus depth and we'll therefore have an increase in our peri-implant disease states. Now, the moment we start talking about occlusion and occlusal overload and the damage that it may or may not cause, it always seems to be a little bit of a controversial topic. And I can assure you that making statements like this is always going to create quite a robust debate. And that's just what occlusion does. It causes that. But I can assure you that my 2 feet are firmly in the camp that believes that occlusion is a determining factor for the long-term success of our implants. So it makes sense that when we look at an occlusal scheme in implantology, we look towards those same concepts and philosophies that we use for natural teeth. Because if you think about it, we're putting that implant into that exact same masticatory system that the tooth used to be in. It has the same temporomandibular joint, it has the same the masticatory muscles, and it has, in a lot of instances, the same neighboring teeth that that tooth used to have. So we look at the concepts of the natural dentition, but then we need to modify it slightly because, as we've said, implants are not the same as teeth. And I'm going to look at that in depth in a little bit later on, exactly how they do differ and what we can do about that. So we must remember that patients will have the same unique envelope of function regardless of whether they are functioning with a tooth or with an implant. And as well, we'll look at the envelope of function because this is a very important aspect that should not be ignored. If we don't respect the envelope of function, we're going to create, in many instances, a restricted envelope of function. And what that means is everything we do falls apart. It results in damage and destruction of our restorations, our beautiful restorations that we have created, our beautiful aesthetic cases will often end in failure because we have not paid attention to the envelope of function. So if we are going to look at the occlusion for the natural dentition, then as dentists and specialists, we have to have a very clear and in-depth understanding of the philosophies and concepts of occlusion in the natural dentition before we can apply that knowledge to the field of implantology. And so I put this slide up, which for me is one of the most important slides that I have, because what it shows is what I want to get occlusal stability in somebody's mouth. And there are 5 requirements for this. And if you get these 5 if you use these 5 requirements to plan your treatments and to make sure that you can tick each one off at the end of your treatments, it is often a recipe for success. So the first thing that we want is we want stable stops. In other words, equal intensity, simultaneous contacts on all the teeth when the condyles are in centric relation. Now, centric relation is in brackets because not every case we treat is going to be in centric relation. If we are only treating a quadrant, then we probably are going to use a conformative approach where we accept the maximum intercuspal position, which is the new term for centric occlusion. We accept that and we treat the patient in that position. But if we are doing a full mouth rehabilitation or reconstruction, then we would be wanting to start our function in centric relation. So that's why it's in brackets, because as the clinician, we have to decide when we are going to treat in centric relation and when we are not. The next point is we want anterior guidance, but we don't just want any old anterior guidance. We want an anterior guidance that is in harmony with the envelope of function. And we'll talk in a moment about that envelope in detail. And then the last 3 requirements all pertain to the posterior teeth. So what we want for the posterior teeth is immediate disclusion. We want immediate disclusion during our protrusive movements, and we want immediate disclusion most definitely on the non-working side during lateral excursions. Contacts on the non-working side during function are some of the most destructive forces that we can get in a person's mouth. And then lastly, we want immediate disclusion of the posterior teeth on the working side, if we possibly can. But in some instances where we have to compromise, we will accept a lateral group function, but then that must be in harmony with anterior guidance and condylar guidance. So these 5 requirements might seem to be quite a mouthful and might seem complex, and you might wonder how I'm going to apply all of this to my treatment planning. But we've all heard of it because the other term for that exact same thing is the mutually protected occlusion or canine guided occlusion. So those 5 requirements, that is what a mutually protected occlusion is. And the reason why we refer to it as mutually protected is because there was groundbreaking work that was done by Williamson and Mahan with some very elegant electromyographic studies that actually showed us that the moment the back teeth separate due to an anterior guidance, we get an immediate shutdown by up to 80% of the elevator muscles. So because those muscles are shutting down, we are protecting our masticatory system. So we reduce the horizontal forces on the anterior teeth during anterior guidance. As soon as those posterior teeth separate, that's what happens. And because the posterior teeth are separating, it makes sense that they cannot wear away or become overloaded because they aren't touching. So even in bruxism, those posterior teeth are in essence protected by those front teeth. And then finally, we are protecting our temporomandibular joints by excessive compressive forces. So this is the system that we wish to achieve, because we know that if we do this, we are protecting our masticatory system. If we are to look at this with articulating paper in the patient's mouth, and this is the maxilla, we would see dots at the back and lines at the front. Now we have dots at the back because we have small contact surface areas. We have a cusp tip to fossa contact, and we have no lines because the moment you go out of centric relation and into any excursive movement, the back teeth separate. There are no contacts during excursive movements. But the lines in the front represent our anterior guidance as we go from centric relation out of that into either protrusion or lateral excursive movements, in any functional movements. And those lines should be a continuous line, and often they are not on the lateral incisors. They are often only on your central incisors due to the shape of an arch, and then we'll see them on the canines during canine guidance. So that is what we are trying to achieve, and it is often easier said than it is done. But if we've got a good goal in mind, sometimes you will be surprised what you can achieve. Now, we have to now look at how teeth differ to implants, because they are very different. And the first thing that we know is different is that teeth have a periodontal ligament. And a periodontal ligament gives us a whole lot of sensory input during function. And we all know about proprioception. Should probably rather be called mechanoreception, because what it is actually doing is measuring force. It's measuring compressive force, tensile forces, and shearing forces. But the literature often sort of makes out as if this is really the only sensory organ that there is to measure force. But in fact, Levy did a whole lot of groundbreaking work as well, which showed that, in fact, the teeth play a far greater role in sensing force than we realized. And if we look at this old picture from our anatomy textbooks, which show the teeth with all their nerves, look how big that cranial nerve is that feeds the teeth. That's what it does. It ends up in the teeth. And those nerves are not just in our teeth so that we know when we're having something cold or hot, or it hurts when we have ice cream. They are there to measure force. And there are millions of little sensory nerve endings that are associated and end in these odontoblastic sensory units. And these sensory units are very little elegant bodies that can measure the slightest, smallest force. And that is one of the main sensory organs in the masticatory system, together with the periodontal ligaments. So obviously we know we can easily work out that an implant doesn't have any of this. This sensory information goes to the higher brain centers, and there it is converted back and sent back along motor neurons to control the masticatory muscles so that they can respond to any minor force that is being exerted onto those teeth, and that is then registered. But I just want to talk as well about the fact that these sensory nerve endings in the teeth and in the ligaments are actually responsible at a very young age for setting the envelope of function for each and every person. So as your anterior teeth erupt out into the neutral zone, they start to make contact with each other. And this contact creates information that then travels along these sensory nerves back to the brain centers. And slowly but surely, you get a memory that is created in your masticatory muscles that is set by the motor neurons. And this envelope of function remains with us throughout our life. And it isn't something that we as dentists or clinicians can just change. It is what it is, and we have to respect it when we plan our treatments and carry our treatments out. Because if we restrict the envelope of function, one thing that is for sure is that when teeth, and we can call it teeth or implants, and muscle war, the muscle never loses. And that's what you will be fighting against, is those muscles of mastication. So this is a very important point to look at. And now we can sort of look at those differences in detail between implants and teeth. Implants have a different occlusal awareness. In other words, proprioception compared to that of teeth. And if we look at teeth have a occlusal awareness of 20 microns. So that means if you put something of 20 microns between your teeth, you will be aware of it. Anything less than 20 microns, the teeth can't register. So I'm going to make the point now that it is obvious then that when you use articulating paper, it should be less than 20 microns thick, because if it's anything more than that, you're going to actually have something to register between the teeth, and it's kind of useless. I would recommend an 8 micron articulating paper, something very thin, or shim stock that's very thin, so that there is no occlusal awareness. But that's natural teeth. If we look at a tooth against an implant, so now we suddenly have an implant that has got no odontoblastic sensory units, it's got no ligament. So suddenly the whole system has changed, and we only have half that sensory information being sent back to the central brain system. So everything is going to be delayed, and it's almost double delayed because it takes 48 microns. It's more than double delayed because it takes 48 microns before you get occlusal awareness, and so that's sort of double. If we look at 2 implants, suddenly it springs up to more than 3 times, 64 microns to get occlusal awareness. So it takes that much longer for the muscles to react to whatever's happening between those 2 implants. And then finally, we can look at a tooth against an implant-supported overdenture, and it shoots up to 108 microns. Now, to explain this very elegantly, I'd like to use the example that Dale Howes explained to me while we were having a chat about occlusion. And what he says is, if you compare it to somebody who's barefoot and they go for a walk along a very rocky, stony path with lots of sharp rocks, you can imagine what that feels like when you've got no shoes on. You can't walk properly. You're feeling every single sensory input into the sole of your foot. And that is what it's like for a natural tooth functioning against a natural tooth in the oral environment. It's exactly like a bare foot. Now, if we go and put a pair of slip-slops or flip-flops on, not thick ones, very thin ones, and we go walk along that same pathway, what we find is we still feel a lot of those stones, but if we walk, it's okay. If we had to run, it would be sore because we would still feel that sensory input through that little flip-flop. And that flip-flop is the same as a tooth which has had a very big resin filling or perhaps a ceramic overlay put over the top, but it's still a vital tooth. So it still has sensory input, it's just a little bit dumbed down. Then what you do is you put on your trail running shoes. That's what I like to do. And I put those shoes on, and they've got a little carbon plate that protect my sole of my foot. And I can then go and run along that path with very little pain. I don't feel much of the rocks. Occasionally, through one of the thinner parts of the sole, a rock will poke me in the foot and it'll be a little bit sore. And that is the equivalent to a tooth that is now non-vital. It has had a root canal treatment, and suddenly it has no odontoblastic sensory units. It only has the periodontal ligament. So the sensory input is less. So we don't feel all that sensory input as we would. And then finally, I go and put on a pair of mining boots, big fat boots, and I go and walk along that road, and I don't feel anything. I feel no stones. I feel no rocks. I can run. I can do whatever I like. And that is the equivalent of an implant. It has no odontoblastic sensory units, and it has no periodontal ligament. So it doesn't have the same sensory input and give the same reactions as a tooth would give. The second thing that we are looking at is the shock absorber ability of a periodontal ligament. So a tooth with a periodontal ligament can intrude up to 28 microns under a heavy occlusal load. It can also move horizontally or laterally by 10 to 50 microns if there's a lateral force being exerted on the tooth. And if we look at an implant, it can't do this. An implant initially has zero movement, can't move. Over a bit of time, if we continue that heavy occlusal load, it will move a little bit, 5 to 10 microns, due to the viscoelastic properties of bone. So these are two very important differences between teeth and implants. And now we're going to look at a third one, and that is that the diameter of a root of a natural tooth is normally larger than that of an implant. And the diameter of a root is shaped according to the function of that tooth in that specific position in the mouth. So if we take a mandibular anterior tooth, it is wider faciolingually because it has to resist the forces of anterior guidance. Those are lateral forces, so it is designed for that. Canines have got a massive root in order to withstand the lateral forces during lateral excursive movements. And then we look at molars, and they have a different design. Their root design is for axial loads. They're not well designed for lateral forces, which again is why it's important that we have immediate exclusion of those molars during function. But when we look at an implant, it's round. It's always round. Okay, the cross-section of that implant is round regardless of the force that is anticipated. So these three differences between teeth and implants mean that we have to find a way around it. We have to compensate for the differences when we look at occlusion on implant retained restorations. And this is just a little picture showing the differences, and the main things that I haven't highlighted here that I want to is that the lateral loading forces in teeth are dissipated mostly apically, but on an implant they are dissipated at the crestal bone. So that's an important point to realize. An occlusal overload on a tooth will lead to widening of the periodontal ligament, maybe loosening of the tooth, mobility, fremitus, and pain and sensitivity. On an implant, we will get inflammation, and often what happens is we'll get bone loss, a crater-like bone defect, but also what we get is failure of the hardware. So we get screw loosening, screw fractures, abutment fractures, and even sometimes implant fractures. So we can see that the tooth has mechanisms to cope far better to occlusal overload than an implant. And with teeth, if we remove that occlusal overload earlier enough, the damage is reversible. With implants, this is not the case. So it brings us to something called the implant protected occlusion, which is, this was developed by Dr. Carl Mesh and Dr. Bedez, which put together a few points that we have to consider, some biomechanical considerations that we have to look at when we are planning our occlusion on implants. And if we do this, we then use the natural tooth's occlusal scheme, changed a little bit so that it will work for the long term. And there are 12 points that we are going to look at. And I'm going to look at each one of these points individually, very briefly, so that we can just look at this implant protected occlusal scheme and be able to apply it on a daily basis. And so the first thing we are looking at is eliminating any premature occlusal contacts. Now this is important in the natural dentition, so obviously it's important with implants. And a little tip is that before you fit any implant crown or implant prosthesis is to actually have a good look at the occlusion of your natural teeth before you do that, and perhaps eliminate any interferences that are existing before you fit the implant prosthesis. And that is done with equilibration. So what we want when we set these contact points on our implants is we want a lighter contact on the teeth with light occlusal force. We want a lighter contact, we want no contact on the implant and only contact on the teeth. Then what we do is we get the patient to bite hard. So there's a heavy occlusal force. And at that point, the shock absorbing ability of the teeth will come into effect and they will move up by about 28 microns. And so then what we want is we want almost equal intensity contact on both the teeth and the implant, so that during that condition, they have a sharing ability, they share the load. So we are not just indiscriminately grinding the crown of the implant out of occlusion in all circumstances. We are doing it in an educated fashion, so that during heavy function, that implant does play a role in absorbing some of that force. Now, another very important tip is that we need to regularly evaluate the contact points on our implant crowns, because it is not a static situation. It is changing all the time because teeth move if they are not in contact. So that opposing natural tooth has the ability to over-erupt and to change what was a good relationship into something that is no longer, and it creates an occlusal overload. And I suggest that all of our hygienists are instructed every single time that they see our patients for oral hygiene maintenance to check the occlusion. They need to be able to check that occlusion and see whether there is now suddenly occlusal overload on those implant restorations. And in fact, they can be in charge of minor equilibration of those occlusal contacts to make sure that we maintain these occlusal contacts for the long run. Next thing we have to do is we have to look at the provision of an adequate surface area to sustain load. So we are saying that the implants are round, they are not necessarily the right shape, and they have less surface area in many instances than the root did. So we have to make a plan to work around that. And so what we have to do is compensate for that increased load that that implant potentially could suffer. And we do this maybe by increasing the implant width. We can do this by reducing the crown to implant ratio. And we can do it by augmenting the ridge. In other words, increasing the vertical, we can have a longer implant, which will increase the surface area of that implant. And then finally, we can, not finally, but we can increase the number of implants, and we can then splint implants together. So all of this is making a plan to increase the surface area so that it can handle that load, because it doesn't have all the same circumstances as a natural tooth. The third thing we are looking at is the occlusal table width, and we've often heard about in areas where aesthetic is of no importance, of perhaps narrowing the occlusal table width to decrease the amount of occlusal force being exerted on that implant. In many instances, our alveolar ridge has shrunk towards the medial, and for that reason, the implant is often positioned to the lingual of the upper teeth. And so for that reason, we often build out the buccal aspect of our crowns in order to have the correct shape. And that often can result in what is called an offset load on the implant, or a cantilever in essence. And we want to prevent cantilever loads wherever we can when it comes to implants. And that's why we can narrow the width of the table in order to do that. And we want to decrease the risk of fracture of the porcelain of that part which we've now extended buccally and created this sort of cantilever effect. So that's the third thing that we can look at to improve the occlusal situation on implants. Now the fourth is my most important point, I think, and that is that we have to create this mutually protected occlusion. So we often have situations where we have natural teeth mixed with implants, and it becomes a very important decision to make as to what occlusal scheme you're going to adopt to get the best possible long-term results. And what we should try and do wherever possible is obviously use the natural teeth for excursive purposes. So if we have teeth in the front, obviously we want our anterior guidance on natural teeth. If we have good healthy canines, we want to use those canines during lateral excursive movements. This isn't always possible. So we have to make a plan as we move along. And so one of the plans we can make is that we make the anterior guidance as shallow as it can possibly be, so that we do not create a restricted envelope of function. So if we're on implants, make that guidance as shallow as it can possibly be. Another thing that we can do, if the canine is an implant, is that we can create a group function. Now that group function can be anterior to the implant, to the canine implant, and make use of the incisors, the lateral and the central, in some arch shapes. It depends. In other instances, we'll take it backwards and use the premolars. And if those are natural teeth, we're going to get some sensory input that we wouldn't get just with the implant, and that would be beneficial. Obviously, we're going to have instances where we have got implants all over the show, and therefore we won't be able to use the natural teeth. And then we're going to have to look at that group function and make sure that it is in harmony with the envelope of function as well as the condylar guidance. And then obviously, if you splint your implants, it improves the stability, and it increases their ability to resist heavy loads. So we have to always think on our feet and look at exactly what the situation is and plan it accordingly. And that is, at the end of the day, if we can achieve a mutually protected occlusion, that is first choice, but it's not always possible. So decide on your occlusal scheme based on the person's mouth and the treatment plan that you are looking at. The fifth thing we are looking at is the implant body orientation and the influence of load direction. And I think this is something we all know, is that an angled load or an angled implant increases the stresses on the implant. And if they talk about a 30-degree or more angulation of the implant to the horizontal, will decrease the compressive strength of our bone by 10%, the tensile strength of our bone by 25%, and then it will decrease the shear strength by 35%. So this is something that we have to bear in mind, and where possible, we have to plan our implants as straight as we possibly can, so that the occlusal load is directed along the long axis of the implants. We want the occlusal load directed along the long axis of natural teeth as well, if we can help it. So it's no different for implants. If the load is angled, then we have to again we have to compensate for that by looking at all those same measures to increase the stability. We can increase diameter, put more implants next to the angled implant, and splint your implants together. And if we do that, we are increasing the situation and making it more favorable for the long term. So we have to look at the angles of our implants. The sixth thing that we are looking at is occlusal anatomy of the crown. What we basically need to do here is dumb down our occlusal anatomy. We don't want to have a highly sophisticated anatomy that's going to result in us creating interfering contact points. We do not want lateral forces being developed as a result of interfering contacts on our cusp inclinations. So you do this by widening the fossa by 2 to 3 millimeters and make sure that the opposing cusp fits into that fossa. So that in essence what we are doing is creating a type of a long centric. We are creating some extra space so that function can occur without restriction, and that we're trying to make sure that the forces will be directed along the long axis of the implant. So open up your fossa and don't look for that perfect occlusal anatomy, because you're often going to work in issues at a later stage. And then we position. So we always talk about prosthetically driven implant planning, but the digital world and digital planning has meant that we are able to plan at another level of accuracy. And it actually means that we can functionally we can do functionally driven implant planning, which means you actually plan your contact points. You plan where your contact points are, and you make sure that on the crown that you are planning before you place the implant, that those contact points are over the central fossa. And then you make sure that that central fossa is over the implant body. In other words, your primary contact position should be directly over the implant body so that those forces can carry down the long axis of the implant. And this can now be done accurately because of digital planning. We can plan our contact point and work backwards from that. The secondary contact point also needs to be planned, and it should not be more than 1 millimeter outside of the circumference of that implant. One of the most dangerous contact points, or most destructive, can be the marginal ridge, because your marginal ridge is actually often quite far away from the circumference or from the periphery of your implant. So we have to think about that. We have to decide where we are putting those contact points right in the beginning and try and plan for success, which is, as I say now, possible in the digital world. The eighth thing we are doing and wanting to do is avoid cantilevers. Cantilevers are just generally a problem, and they create such a huge amount of force on the abutments and on the implants that are holding that structure. And it's twice the load is applied to the implant furthest away from the cantilever, but it's 3 times to the implant closest to that cantilever. So it's a massive force that we are exerting. And we all know about the AP spread, the anterior-posterior spread of implants, that the cantilever must never be more than 1.5 times the anterior-posterior spread. And we never want contact on a cantilever. Cantilevers must always be in infra-occlusion, even under heavy load, even under a heavy occlusal load. The 9th thing that we look at is reducing the implant crown ratio. And this is very important because the high crown ratio will cause a vertical cantilever. So in other words, you're going to create lateral forces on our implant, which we know are detrimental and cause harm. But we have to remember that you can't plan the crown implant ratio during the restorative phase. It has to be planned at surgery, and you have to decide how you're going to decrease that ratio, either with the surgery that you're going to carry out, with augmentation, to improve that ratio where possible. You must select the best material for the crown that you're going to choose. Now, this isn't a lecture about material, so I'm not going to get heavily into this. But we have to look at what the opposing dentition is. What is the material? What is the neighboring dentition of the implant in the quadrant that we are restoring? And just remember that you have different materials. And that's not in the right order, because A resin hybrid is your most flexible. In other words, it has almost a shock absorbing potential for the implant. It then is your metal, followed by porcelain, and then zirconia. And when you get to zirconia, although it's an amazing material and one that I'm using more and more, it's like putting concrete on top of your implant. So if you're going to do that, you have to be aware of that fact, that it's a very hard material with no flexibility and no shock absorbing ability. So we have to compensate for that, because it has other advantages which we may want to include. So we look at material. Then we have to analyze for parafunctional activity. Now, this is important for any restorative situation. If you are doing a full mouth reconstruction, or you have to look out for parafunctional activity and make sure you protect what you have built from that activity. If you have parafunctional activity with a poor occlusion, it is even more destructive. And that can definitely lead to the failure of implant bone loss and failure of the entire structure. It can lead to the failure of teeth as well. So we have to watch people that are Braxers, make sure that we have the perfect occlusion, and on top of that, that we don't have cantilevers, that we have the correct contact points on our crowns, and that we give them a night guard that must be used, that is their insurance policy, that they have to use every single night to prevent the overloading of implants. We can time the loading of our implants as well. So you get delayed loading, progressive loading, and immediate bone loading. And it depends on the bone density. Progressive bone loading is what we would try and prefer to use in less dense bone, because it allows the bone time to adapt. As you increase the occlusal force, the bone becomes more dense. And we have to do this gradually over time. And there are various methods that one can use in order to try and do this. It can be done with time intervals over 3 to 6 months. You time the amount of contact that you create on your implant. The literature talks about diet. Now, I'm not sure if any of your patients will listen to you if you tell them for the first month to eat soft foods and then thereafter gradually increase the intensity or the hardness of the foods. That's going to be a hard task. But it is something we should tell our patients nevertheless. And then what we really should be doing is gradually intensifying the occlusal contact on a provisional restoration on our implants. And this is done in conjunction with different types of materials. So our provisional will be a resin, which is a more flexible, softer material, and it allows us to bond onto it so we can gradually increase the contact point over time. And eventually, when that has happened over several months, we can then finalize our materials and then change to the harder non-flexible materials. So you use a combination of increasing contact strength and materials to slowly load the bone to increase the density over time. So these are the 12 points that one should look at with the implant protected occlusion. And I just now want to show you a few, a few cases where we look at different parts of the mouth in order to address occlusion. So the first thing, we look at the anterior arch. So if we are placing implants in the anterior component of the arch, we have to remember that the anterior guidance should be as shallow as possible, and where possible, splint your implants together to give them some increased support. We want equal intensity contact, simultaneous contact on the implants in the front as well as the natural teeth at the back. This is very important for a mutually protected occlusion, so that that load during centric relation can be shared between the teeth and the implants. We want, in lateral excursions, we would love them to be on natural teeth. So if we've got a healthy natural canine, and it's possible, we should look to have the lateral excursions on those teeth where possible. So if we look at a case that I did actually a long time ago, where the 1-1 and the 2-1 were suffering from replacement ankylosis, so they were being resolved, and the patient came to us not because of any pain or symptoms, other than the fact that it was not aesthetically pleasing anymore. It was discoloration, and in fact the gingiva had started to grow into the resorption, so there were these pink areas along the gingival margin. that's what it looked like on a radiograph. And you can see that it wouldn't be long before these crowns would snap off if we didn't deal with it. Now, when you look at this, this is where you have to think functionally and look at it and decide. The first thing that everyone is thinking, well, how many implants? How many implants are we going to do to replace those 2 teeth? And if we look at it biologically, well, then 1 implant is often what is considered to be the best option. But in a case like this, if you look at it and you think about it, the anterior guidance in an arch shape like this is all going to be on the central incisors. So as you go into protrusion, all of that force is going to have to be on those implants that we place. Now, the good aspect is that we have natural teeth in the lower, so at least we do have some sensory input from the odontoblastic sensory units and the ligament from the lower teeth, but still, all of that force, all of that anterior guidance is going to be on the implants. So if you put 1 implant in, now remember the rule states that you can have a 0 contact on the cantilever, it means all that contact has to be on that 1 implant during anterior guidance. So from a functional point of view, if the biology allows for it, I would rather have 2 implants. I'd rather have 2 implants to share that load of anterior guidance. So that is what we planned and try to put into place. Now, if we look at the CBCT, we can see that the biology did allow us to have at least 3 millimeters between our 2 implants and more than 1.5 millimeters between the implant and the tooth. So that was favorable for the placement of 2 implants. And if we have a good connection, a good Morse taper connection, then I felt that 2 implants would be a very good option from a functional point of view, and it would work biologically as well. So that's the decision that I made. I chose to choose 2 implants to replace those 2 teeth. And the patient wanted an aesthetic result. So you can see all of the force is going to be on those 2 implants during protrusion. The patient didn't want it to be splintered, but splinting would increase your protection of the implants from occlusal overload. The patient wanted longer teeth, so we've actually lengthened those teeth, and we have to make sure we are aware of that when we work in our occlusion. So you actually have to make sure that your anterior guidance is in harmony with the envelope function. I don't have time to go into that now, but there's a specific procedure to achieve that. Another case, sorry, that's the end result, and that's what our X-ray looked like after completion. Another case, which is a lot easier to handle from a functional point of view, is 3 missing teeth, and we now have to replace that with implants. Now, because if we place 2 implants and we then have a 3-unit bridge which splints them together, I feel that there's adequate support for those 2 implants, and I certainly wouldn't want to go and throw a 3rd one in between there because I don't think it's necessary. So anterior guidance, again, is going to be, there's the end result, is going to be on the lingual surfaces of those anterior crowns. In this instance, there was a little bit of contact made on the lateral incisor, and then after that, at the end, all of the occlusal forces were on the 2 central incisors. So effectively, because they are splintered, both implants will share the load, and 2 implants is more than enough from a functional point of view here. So that's how we did that. Now, this is when the patient is biting heavily. And when they bite heavily, we want to see almost even contact on both the implant prosthesis and the teeth. With light contact, we wouldn't want to see any contact on that implant prosthesis, or at least very little. And unfortunately, I don't have a slide showing you the anterior guidance, but we would want to see with red articulating paper. So we use blue articulating paper to represent our centric relation contacts, and we'll use red articulating paper to represent our excursive movements. And we would want to see a solid red line from that point of contact all the way to the incisal edge on those central incisors. And on our canine, which is natural, in both instances, they're natural canines, we'd want to see the same thing during lateral excursive movements. That's the end result for our patient, and that's what that looked like, VMK, to create a 3-unit bridge. The next thing we look at is placing implants into the posterior arch. Okay, so now we're putting implants in the back areas. And what's important here is that the anterior guidance must use the natural dentition, and we must use the natural dentition during lateral excursive movements if we've got healthy canines. If the canines are compromised or the canine is one of the implants, then we'll want to look at group function. Having said that, if my opposing teeth are natural and I have vital teeth with a full complement of sensory nerve endings, and they are going to function against that canine implant, in many instances, I'm not going to go and look for a group function. I will accept a canine guidance on a single implant if I have a healthy situation in both the canine implant and the canine tooth. But this is judgment, which you have to decide for yourself depending on the specific case. Now, immediate disclusion of those posterior prostheses on our implants is imperative. So we want to make sure that contact is lost immediately as you move into protrusive and lateral excursive movements, because we don't want any force on our implant prostheses during function. And then obviously any cantilever, we want an infra-occlusion by 100 microns. 100 microns is what we look for. So if we look at some cases, this is just a full rehabilitation that I did, and I'm just showing you one part of it where we were restoring some implants in one of the quadrants. But in order to make sure that you have immediate disclusion of any restoration, whether it be on teeth or implants, you need a semi-adjustable articulator, and you need a face bow in order to measure, or in order to accurately copy the arc of closure or the arc of opening. And then we are able to check, and our technicians should be checking for us, that during protrusive or excursive movements, those teeth are not making contact. And in fact, they must immediately separate. And this can be seen with articulating paper. And it's advisable to not just look at, to be focused tunnel vision on what you are treating, but look at the rest of the mouth while you get an opportunity and make sure that there's no, for instance, non-working side contacts during lateral excursive movements. Because if there are, this is something that you can deal with before you fit your implant prostheses with a little bit of equilibration, if it's possible, if it's a viable option. And it's not going to lead to mutilation of the enamel. We don't want to do that, but that's why you have to analyze it on an articulator. And so these were not splintered. This is using, to me, which is a material that is my go-to material in many rehabilitations, which is Emax lithium disilicate. And so these implants would have had some form of a mesostructure or a substructure of zirconia, and then the Emax is bonded on top. And it is an unbelievable combination between strength at 500 megapascals and aesthetics, and we have to give Emax lithium disilicate its credit. So it's a fantastic material, but you'll see in a moment it's not the only material when it comes to implant dentistry and when it comes to long span bridges and superstructures. This is the case, and I just wanted to show this picture because this is what dots at the back and lines at the front would look like in a rehabilitation. So we see the green represents the centric relation contacts and the red represents function. And we want to have a continual red stripe from the point of contact in the anterior guidance all the way to the incisal edges. But we want to see none of those red stripes on the posterior teeth because we want immediate disclusion of those posterior teeth during function. So you'll only see the red on the blue in centric relation. But other than that, any other red on your ceramics needs to be adjusted. You need to get rid of it. You need to grind it away so that we have immediate disclusion of those teeth. But that's what dots at the back and lines at the front look like with the lithium disilicate reconstruction. Now, this is a case that I also did do long ago, and I obviously would have done it very differently with the knowledge that I have today. But I did this just before the socket shield became the go-to option. And I had decided that I didn't want to place an implant in the 2-4 area because I didn't want to extract that root and lose all my bundle bone and lose the entire buccal surface, which would have aesthetic consequences. So I planned this case with a cantilever. Now, cantilevers you've got to try and avoid, but in this instance, I was trying to get a balance between aesthetics and a balance between keeping the bone and occlusion. So there's 2 implants that are being planned with a cantilever moving forward. That back tooth is a crown on the natural tooth. So that is exactly what we did. But in doing this, in the planning, we have to make dead sure that there is immediate disclusion of that superstructure during function. We have to make sure that there is no contact on the cantilever. And if we do that, then we should achieve success. And this is what that case looked like. We had a healthy canine in the area to handle the stresses of lateral excursive movements. I kept that root because I wanted to keep my buccal bone. I ended up root treating it and placing those 2 implants. So in today's terms, I would have much preferred now to have not had a cantilever and used the socket shield approach to achieve exactly the same thing, but not have a cantilever. It would have been a much better result. And that's what I would do today. Then if we look now at a full arched fixed implant prosthesis, we have to decide on certain things here. The opposing arch is a denture, then we have a balanced occlusion. We go back to our denture days. If the opposing arch is a natural dentition or another fixed full arch on implants, we look at a mutually protected occlusion or groove function. Any cantilevers must have no contact on them. Remember though, as long as 2 implants are joined together, contact on the pontic is not an issue. Contact on the marginal ridges is not an issue because they are splintered together. It's only when you have a cantilever that we want no contact on that aspect at all. And then we must create a freedom in centric by 1 to 1.5 millimeters in implantology. So freedom of centric, just to explain it, is creating enough space for the person to function without any interference and without any restriction of the envelope of function. This means what you do is in the anterior area is the patient sits upright and they chew on some articulating paper and you don't support the jaw. They just chew and move their jaw around up and down. And then you put them back and you manipulate them into centric relation and you register centric relation. You'll do them with different occlusal articulating paper colors. So perhaps blue when they're in centric relation and red for their postural upright functioning position. And any red that is in front of your blue contact position needs to be reduced because that is an interference that's going to cause damage and harm later on. So that is what we mean by freedom in centric. So this is a case where we had a full arch reconstruction that had failed on the upper jaw. I want to draw your attention to the fact that this person is wearing pretty much trail running shoes on the lower jaw. In other words, there's a big bridge there, and we're going to definitely have had a loss of sensory input from those natural teeth. So we have to bear that in mind with our planning. In this instance, it was not really, the teeth were not salvageable. There were no ferrules. It wasn't something that we could save. I am quite conservative, and I decided to do this in a staged approach. So we first looked at placing 4 implants in the posterior areas, using provisionals in the front for the time being, and actually completing that before I would move on and place 4 more implants in the anterior arch, where this would then be used to create 4 individual 3-unit bridges. I prefer to do this so that if we have any chipping or problems, we're not having to deal with an entire full arch that has to be redone or remade. You've got 4 different very short spans which can be dealt with if there's any complications that arise. So this was my plan for this case. And in the end, it looked like this. And you can immediately see that we've used zirconia. Zirconia is like concrete. We have to remember that. And already they're wearing trail running shoes on the lower jaw. So you have to take this all into account if you're going to use a material like that, and make sure you have the perfected occlusion that functions perfectly so that we can do everything in our power to prevent occlusal overload. You may ask, well, why are you using zirconia what are your options? If you're doing bridges, it's either going to be a BMK or it's going to be zirconia. And the thing that has changed my outlook, because I can tell you a zirconia substructure with layering over the top was a recipe for failure in the years gone by. But with full contour zirconia now coming into the fore, this is a fantastic option because you are getting that amazing strength of zirconia with no chipping and breaking. The problem obviously with the full contour is aesthetics, but that has now changed. And we now have the amazing highly translucent zirconia like the Zircad Prime, where they use their gradient technology to create this amazing material that has translucency, and it has a layered effect already built into it. So you can actually use it for full contoured monolithic zirconia in aesthetic areas. And so this is the completed arch. And I want to point out that I used a full contour zirconia in the posterior arches, but you can see how different it looks because it was not the newer materials that have the highly translucent and layered effects. It was still a full contour zirconia, so we get all the benefits, but we don't need to worry about aesthetics in those back areas. But look how it compares to the zircad prime that you see in the anterior, where you have this totally different translucency, and it allows us in cases where to achieve a very acceptable aesthetic. So this lady's in her 70s, and this is more than acceptable from an aesthetic point of view. So we got aesthetics, we got a very, very strong material, but we then had to make sure that our occlusion was spot on because we were incorporating something that didn't have much give as far as transferring forces onto the implants is concerned. So that was a full arch case. And then finally, very quickly, I'm not going to spend much time here. I'm going to look at the mucosal implant supported overdenture. Here we have to look with our occlusal schemes to those prosthetic principles, where we look at a bilaterally balanced occlusion, and where possible, we look at a lingualized occlusion. In cases with severely resorbed ridges, we have to go monoplane occlusion. The difference, if you're not sure, is that a lingualized occlusion, we are trying to have the upper teeth still to have some anatomy so that they are aesthetic, but on the lower teeth, they're more flattened down, so they're more monoplane. And then your upper lingual, on the maxilla, your lingual cusps are the only cusps that are going to articulate with the lower teeth in centric relation, protrusion and lateral excursion. So that's a lingualized occlusion, but in some instances it's not possible, and then you have to go monoplane upper and lower, which isn't as aesthetic. This is just a case where we did an overdenture, replaced an old denture. This is called a syncone concept, where we make use of gold copings that then get passively cemented into a superstructure, a bar. The bar was done with CAD-CAM in this instance, and those gold copings are then cemented into the bar, which is then fitted into the denture. So this is a great solution for patients for oral hygiene purposes, because they take the overdenture out and then are able to clean those implants very, very well, compared to if the bar is attached in the mouth. And these telescopic copings have an amazing fit, and sometimes it's too much of a good fit where patients then struggle to get it out. But there is no instability here. And for me, my preference is, if I'm not going to go with a full fixed sort of porcelain type of structure, I prefer an overdenture with a telescopic type of design to a fixed hybrid. Fixed hybrids for me don't work well. They don't work well in my hands, so I would prefer an overdenture. And so that is the end result for that case, and that brings me to the end of my presentation. I hope it's been informative and useful, and I hope you've learned something from it. Thank you very much, Stephanie.
Thank you very much, Andrew. I don't have any questions popping up on my side, so either you have really covered everything, or everyone is looking for that course to sign up. We also had you live on Facebook, so if any questions are coming through from Facebook, Paula will be posting them in the chat box. But for now, if there's any questions from the floor, Andrew, you can take your screen off share screen, and then anyone can pop on their videos and they unmute themselves and just ask the question directly to Andrew. I know often if you want to ask an occlusion question, it ends up like writing out a story. So sometimes it's just easy to take part in the discussion. So let's just give 2 minutes for the people to get their confidence together to ask a question.
That's the only bonus about talking about occlusion, is that often people don't ask you any questions. But I'm joking. I hope there are some questions. So if anyone has got anything that they're not sure of, or anything at all, then I'm happy to answer any questions.
Good. While we do wait for some questions to pop on, I just want to take time. We do have face visors back in stock and some N95 masks. So if anyone is looking for them, haven't been able to find them, please pop an email to orders@ivodent.co.za. The office is open and they are ready to help you guys.
Thank you, Sally, for that comment. I appreciate it. I just want to actually look at the chat and see.
Okay, I think before everyone pops off, Andrew, thank you very much for your time. I definitely learned quite a bit out of this lecture yet again. I will definitely recommend everyone to start following the SAD online platforms. These are the real aesthetic dentistry courses that will change the way that you do dentistry. Catch this session to rewatch and all previous sessions on Ivodent Essays YouTube channel and Facebook page.
Okay, I see there are some questions that are popping up there, so maybe we should have a look there and just address some of those. So I'm just, in terms of a night guard, is it an acrylic stabilization splint? So yeah, I mean, you're referring to a Michigan splint, and it would be that. Just a very important point that I would like to make is for everyone to understand that a Michigan splint is not an easy thing to make properly. And we have to remember that they have to be made with extreme detail so that they are doing exactly the same thing as far as the 5 requirements of occlusion are concerned. They have to fulfill those functions. And so you need that to be designed on a semi-adjustable articulator with a face bow so that it is done correctly and properly. And that costs a fair amount for that patient, but they need to, that's what they are paying for, the time that it takes to then get that ground in and to be functioning correctly. So yes, it would be sort of an acrylic type of full arch splint. The question is, do you find that CEREC helps with your occlusal design? I don't want to talk about any products, but what I will say is that digital planning and digital design allows you to exactly plan your contact point to the exact micron that you want. So you can decide exactly how heavy you want it to be. And if you look at the colors on your natural teeth in certain programs, you'll know under heavy occlusion how many microns the natural teeth are exposed to. And so you can make sure and mimic that when you plan your contact point under heavy occlusion. So you ask your patient to bite hard, and then you know that the contact point on your implant crown must be a similar intensity to that of the natural teeth. So digitally, it opens up a whole new level of accuracy that we never had before, and it allows for functionally driven dental treatments, which is what we should strive to do. It's the next level up of accuracy, and it's what we should try and do. And then I think that's the last. Is there anything else, Steph? No?
I'm not picking up anything else from my side, Andrew. So thank you very much.
Everyone's asking about these visors, so perhaps I should put one on for you. There you go.
There we go. Thank you very much. There was one question. They were just wanting to find out, do the loops fit underneath the visors? Yes, they do. Yeah.
The only important point there is you can't use your light.
Yes.
The light will reflect off the plastic and then you can't see properly, but the loops do fit. Unless you've got 4 times, then maybe it might bump, but it works. My loops work extremely well, and this has a very comfortable fit on the forehead. So this is a great product, I have to say.
Thank you very much for that. All right, guys, that's everything from my side. We will be sharing our lecture topic for next week, Thursday, in due course. Be sure to join us, where more local dentists will be sharing their many success stories. I hope you all have a lovely evening, and we'll see you back next week. Same time, same place. Good evening.
Thank you, Stephanie. Good evening, everyone. Goodbye.
Like it on.